Hello, my name is Toby Richards and I'm a senior lecturer in surgery based at University College London. My interest is in preoperative anemia management and in particular the impact and efficacy of iron treatments, not just for the treatment of anemia but also for the treatment of iron deficiency. In the course of this talk I'm going to go through the problems of anemia and transfusion in surgery and how the current solution of a blood transfusion for perioperative anemia may not be the most appropriate or best solution. It should be pointed out that the blood transfusion service is an excellent service of very high quality. So to start off, my disclosures of interest. I've got a lot of industry collaborations. I work with all the companies involved in iron therapy, and I do a lot of work on device and interventional trials. I run 11 clinical trials back at UCL, and I held a series of grants both from the government and from industry collaborators. In particular, in line with US guidelines, we have to declare any conflict of interest over $10. So I'd like to thank Costa Coffee in particular, where I've done many a meeting. So, as mentioned, I'm going to talk about what is the problem, i.e. what is the problem with preoperative anemia. As you know, many surgeons are keen to push ahead with cancer surgery, and they may be missing a reversible risk. And with outcomes being reported in the press, this is an important factor to take forwards. Patient blood management is a phrase that has been coined initially by James Isbister here in Australia and has now been adopted internationally. In the United Kingdom, the NHS Blood and Transplant Service, who run the blood transfusion service, have adopted patient blood management as the future of transfusion, and this is endorsed by our Chief Medical Officer. So what's the problem? This is my day job. I'm a vascular surgeon. Vascular surgery uses more blood than any other specialty outside cardiac surgery. In fact, if you look at patients coming into vascular surgery as an emergency, on average, most will get 2 units of blood within 48 hours of admission to hospital. Yet this is often overlooked. Despite the fact that we're increasing local anaesthetic, we have more attention to detail, and specifically keyhole surgery or laparoscopic surgery, what you're really seeing is sicker patients who are getting older with more comorbidities, and we're doing more advanced and more technical operating, far longer procedures that previously we weren't doing. So blood transfusion does remain a problem. In the UK, enhanced recovery after surgery has become a major driver for change. One of the main reasons behind this is to save time and therefore money by reducing length of stay of patients in hospital. So we can argue that enhanced recovery after surgery is for the benefit of the patient in reducing complications. I would argue that there's actually no evidence to support that whatsoever. There is no evidence that I'm aware of that enhanced recovery after surgery improves patient outcomes either in the short term or the long term. However, if you use an endpoint of length of stay in hospital, then yes, you achieve a benefit, but is that a benefit to the patient or a benefit to the hospital? And I'll let you think on that as an endpoint. And one of the key features when looking at trials and looking at particularly this area of patient blood management is to bear in mind the primary endpoint for which the study was designed for. So if you look at Henrik Kellett's work, who we all know very well, who pioneered enhanced recovery, developing this into the UK situation, if you look at this slide and you look at the average length of stay for these key 7 major operations, if you can reduce the length of stay by 4.5% in this patient group, you'll save 250,000 bed days in the UK. Now, the cost of a bed day in the UK is £258 per day on our current coding scheme. So I'll let you do the maths. So what's the problem with anemia? Well, there's been a variety of studies. A lot of small, simple cohort studies, which can be retrospective or prospective in nature. However, some of the big data series come from the NSQIP database. The NSQIP is the Quality and Safety Improvement Program in the United States veteran hospitals. The way this database is designed is that in the 190, almost 200 hospitals in the network, the The first 3 operations every week performed are loaded onto a key database. The data that's included is quite extensive. It's 3 pages and about 78 variables. It includes preoperative, perioperative and postoperative outcomes. So if your hospital does 17 hernia operations, only the first 3 are recorded that week. And that way you get distribution of all non-cardiac surgery from primary hips and knees through hernias, from major colon resections, etc., etc., etc. Access to these databases have been made available in the last decade and have really exploded in the last few years. Looking retrospectively at these datasets, which are over 150,000 patients per year, anemia has been associated with an increased risk of perioperative infection, cardiac events, length of stay and composite outcomes. And further, when you try and add in transfusion, this has been associated with an increased morbidity and mortality. These data were done in selected groups, either in emergency surgery, colorectal surgery, or orthopedic surgery. And so we wanted to look in more detail and try and tease out and dissect, does anemia impact outcome in this patient group? Or is, as people suggest, older, sicker people tend to be more anemic, which we know. But is anemia an independent variable for outcome, or is it just a marker of a sicker person? So to do this, we looked at 2 years of the US veterans data, 250,000 people, and the anemia rate was 30%. 30% is about average for all people undergoing major surgery. If you look in colorectal surgery, it'll be 50 to 60%. If you look at primary joint surgery, it'll be 10 to 15%. If you look at revision joint surgery, it'll be 20 to 30%. Hysterectomy, it's about 25 to 30%. Across the board, it's about 30% in all areas. So we looked at 30-day mortality. We looked at 9 predefined areas, either cardiac morbidity, respiratory morbidity, CNS morbidity, VTE, etc. And we looked at over 60 covariate factors. So these are the stats. This is the univariate analysis of across 9 predefined areas and 62 predefined domains. I'll let you do the maths. But essentially we took these data, which are pretty extensive, and we did a multivariate analysis controlling for all these factors. And these are the results. We showed for a stepwise reduction in your hematocrit, there was a stepwise linear increase in outcome, both in mortality and also in morbidity. Across the board, if you had any form of anemia, your risk of major morbidity was increased by 40%. And that was whether or not it was mild anemia or severe anemia. And the same effect was seen for mortality. Again, these are associative data, so it's not causal, and we can't prove it. But if you look at those data in detail, this is the best analysis that is available in the literature to date, showing a linkage between anemia and outcomes. So what about transfusion? Well, what's interesting about transfusion is coming more in the press. If you look at the serious hazards of transfusion reporting, which is a UK-based thing, we're seeing a rise in serious hazards being reported. This could be because awareness is more common, and therefore people are more prone to reporting. However, in the recent trial from Barcelona, looking at the use of transfusion in GI bleeding, what's interesting is that they had a specific endpoint looking at adverse reactions to transfusion. In this trial, they took people who had major GI bleeding, and there were predefined criteria for that. They were randomized to a liberal or restricted transfusion policy. Without going into details, transfusion reactions were reported in 9% in the liberal group and 6% in the restricted group. And reactions to transfusions we normally associate with a major ABO incompatibility or an anaphylactic reaction or a febrile reaction. However, you must bear in mind now transfusion-related circulatory overload, TACO, which is increasingly common. And actually, if you look at the ABA or the NHSBT website, is reported in 1% of all transfusions. In the sicker, the higher risk group or the perioperative group, that risk may be higher, as evidenced by the Barcelona trial. So although transfusion and the delivery of a blood product is an excellent service, it is associated with risk, and it's not the benign procedure that we originally thought. And if you look here at how blood is used, what you're looking at is a whole variety of different institutions in the UK and the transfusion rates for simple coronary artery bypass grafting. This is the same procedure done in different centres, and this is what a benchmarking study looks at. The original benchmarking studies were done by Hans Gumbolz in orthopedics in Austria and showed a similar wide distribution. There's no real logical reason for this. And can we explain why Hospital Centre A has a transfusion rate of almost 80%, whereas other people for the same operation are doing transfusion rates of 25%? Looking at this in more detail, Victor Ferraris also looked at the US Veterans Database, and he looked at just under 1 million people and teased out, with a similar analysis to ours, the impact of transfusion. And what you see here is that even a single unit of blood is associated with an increased risk of morbidity and mortality, controlling for all those other variables compared to those who didn't receive blood. And what you're seeing here is a trend that is very similar, that appropriateness of transfusion is the key here. It is not that transfusion necessarily causes harm, it's whether or not you've been giving it in the appropriate manner. So what's really dangerous? Is it the anemia or is it the transfusion? Is it the chicken or the egg? We don't really know, but I'll present two sets of studies trying to dissect this out. In the United States, the dump for data for all cardiac surgery is made into Duke, and this is an analysis of just under 250,000 people undergoing on-pump CABG. And what you can see here is that the incidence of anemia is 30 to 40% in all people undergoing cardiac surgery. What's interesting is exactly the same response. The transfusion rate is associated with the hematocrit at entry into surgery, unsurprising. And anemia is associated with increased overall 30-day mortality, stroke, renal failure, post-operative complications, and infection. Transfusion was similarly associated with the same outcomes, but if you controlled for transfusion, the impact of anemia was only seen in the endpoint of renal dysfunction, which is an interesting one because the quality of this study is only as good as the data and the endpoint being assessed. We all know that renal dysfunction in cardiac surgery is the biggest marker for mortality. Yet, these data didn't show an impact on mortality, they showed an impact on renal dysfunction. So there's a need to read this paper in detail to tease out how that primary endpoint was defined. We looked at gynecological surgery. So we took our US veterans data, and one of the criticisms is, okay, you've shown association again, but this could still just be association between an older patient with higher comorbidity. So we wanted to look at a younger group who is relatively fit and healthy, undergoing a fairly homogeneous procedure. So we chose hysterectomy, and we chose either benign or malignant hysterectomy, here defined as a simple or a complex hysterectomy. We chose younger people, average age of 48. So essentially we're talking about young, fit, healthy women undergoing relatively routine, relatively straightforward surgery, simple hysterectomy being 90%. On average, about a quarter were anemic, and the incidence of transfusion was significantly higher in those patients who had anemia. Across the board, doesn't matter what population it is, if you have preoperative anemia, your risk of having a transfusion is 2 to 3-fold higher than the non-anemic group, and on average you get 3 units of blood instead of 2 units of blood. That's the same for cardiac and non-cardiac surgery, and in my experience it's the same in every population I've looked at. So there's nothing new on this slide. However, these are the 9 predefined domains. Any form of preoperative anemia was associated with a higher risk across the board. And again, this is a fairly homogeneous group of young, fit and healthy women. We did a sub-analysis of this, and we took the complex hysterectomies out, and the results were exactly the same. But what you're seeing highlighted here is that the overall mortality rate was 1 in 1,000 if you were non-anemic, but it was 1 in 200 if you were anemic. and therefore for the average hospital and average size, every year one person who's anemic dies. Now, is that normal, or should it be corrected? What you see from this slide is we've tried to dissect out whether or not it's anemia or transfusion that has the impact on the outcome of morbidity and mortality. The two graphs you see on the bottom are propensity scoring graphs. These show that for a declining hematocrit, the odds ratio of having a morbidity or a mortality is increased. In the top slide, we've adjusted for transfusion in addition to the anemia. And consequently, what we're seeing is that in terms of an endpoint of morbidity or mortality, preoperative anemia accounts for 60% of that, and transfusion accounts for 40% of that effect. So this is a statistical modelling, but it shows that the impact of transfusion is not a good solution for the management of anemia. It shows that it adds risk to already an at-risk patient. Other endpoints that need to be looked at are postoperative morbidity scores, cardiopulmonary exercise testing, and cost analyses. There are other things that do exist, but these are the areas of work that we've done. Postoperative morbidity scoring is a tool set up in the United Kingdom from Source and work done by Mike Grocott. What this does is it doesn't define someone as having a complication, it defines a morbidity. So, i.e., does a patient require intravenous antibiotics? Do they need to be on supplementary oxygen? Are they having a urinary catheter with hourly urinary output? And you measure this on different days 3, 5, 8, and 15. And you can get a score per day, and it's a measure of morbidity. What we showed is that if you had preoperative anemia, you were more likely to have a higher morbidity score on the days that it was measured. And if we controlled for transfusion, you showed that preoperative anemia was associated with a higher morbidity and also a higher length of stay in this patient group. So this is a doctor's impact on a patient's morbidity. It's not a patient complaining of a morbidity or a complication. It's just a measure of recovery after surgery. The POM score has been validated in various small studies, but as you know, complications after surgery are relatively poorly standardized and validated. You can use the Clavier-Dindo score. However, how many of us use that in routine clinical practice on a day-to-day basis? So I put it to you, watching this video, what is a good way of measuring recovery after surgery? If you want to look at transfusion rates and in the impact of transfusion, the results are exactly the same. So this is controlling for anemia, and I'm repeating the same story here. But we showed that transfusion was associated with a significant increase in delayed recovery. Fairly self-evident, because if you're in a bed receiving a transfusion, by definition you need to stay in hospital for an extra day, and by definition you're receiving an intervention. But what about fitness? How do we measure fitness? Preoperatively, you like to do some fancy tests. We can do some cardiac tests, we can do an echo, we can do a stress thallium, costs thousands and thousands of dollars. We can do lung function tests, or we could put someone on an exercise bike or walk them up 2 flights of stairs. Cardiopulmonary exercise testing has grown increasingly common to identify those patients at higher risk for surgery as defined by the anaerobic threshold or their VO2 max. And local institutions will have local cutoffs such as an anaerobic threshold of 12. What we've done is correlate your VO2 max with your hemoglobin levels. Now, in the patient population, the scatter diagram for correlation between VO2 max and hemoglobin is variable. And really what you need to be looking at is total hemoglobin mass. So an endurance athlete, a top athlete, will have the same hemoglobin concentration as us, but they will have more hemoglobin circulating because they have a greater volume of distribution than the average patient. So again, the variable assessed here is hemoglobin concentration, and I put it to you to think on this. Is that the most appropriate variable we should be looking at in this patient population that are unwell? For instance, if you've got someone who's got cardiac disease and they suffer with edema, is the volume of distribution of their hemoglobin the same as someone who doesn't have edema? And therefore is the concentration, the hemoglobin concentration, as accurate in that patient as another patient? And you, as the anaesthetist, will be making the decision on how to manage that patient based on that variable. So I challenge you again to think about the variables that are assessed before making a decision on future intervention. Digressing slightly, coming back to this slide, we showed that there's a direct correlation between hemoglobin and VO2 max. And we know that VO2 max impinges on recovery after surgery. What about cost? This is taking the coding from hospitals in the UK, and we match the codes across colorectal, urological and orthopedic surgery, and we showed that if you have preoperative anemia, you have a higher complication rate as defined by the different coding seen in the hospital. So the irony is that preoperative anemia is associated with a higher cost, although ironically the managers were happier because they were getting paid more for each patient.